We are going to be talking about a topic that's near and dear to my heart, and Dr. Harris knows this too. We're going to be talking about neuropsychology, talking about doing work in clinical psychology that is focused on the brain, so to speak, more like focused on functioning, right? How do we function in our world using this big, massive muscle that we have between our earlobes? So, we are joined by Dr. Matt Harris, who is a clinical neuropsychologist and is practicing in the lovely state of North Carolina. Did I say
North
that?
Carolina. Yep.
North Carolina. Matt received his PhD in clinical psychology from Align International University, the Clinical School of Professional Psychology in San Francisco. Likewise. Um, and before that, he obtained his bachelor's degree in psychology from the University of California, Santa Cruz. Um, he currently specializes in research, statistics, and neuropsychology, and he's licensed to practice in North Carolina, where he currently resides. Currently, he is an assistant professor at the University of North Carolina in Chapel Hill, where he works as a clinical neuropsychologist and is involved with several research studies, along with supervising students slash interns and teaching a class now and then. We'd love to hear a little bit more of that. He's also on the board of the directors of the Brain Injury Connection, a nonprofit organization dedicated to helping those with acquired brain injury. We'll talk a little bit about what that is. He also has a long history of statistics consultation, tutoring, and working as a professor and research assistant. English. I can do this. More importantly, he is super ecstatic to be involved with TogetherWell and is happy to provide the perfect combination of things, his love of research and helping people, as well as promoting education for those who need it. So thank you so much, Matt. Dr. Harris, what would you prefer that I call you?
Let's go with Matt. And thank you so much for the long introduction. It's not your fault it's long, but good work at making your brain tell your mouth what to say during that whole thing.
Right? So let's talk about the brain. We're always talking about like, we're tired, or, it's been a long day. My brain is tired. I know I say that all the time. So let's help folks understand what that even means. Like, what is our brain doing? So, understanding how we use our brain and how our brain helps us function throughout the day is something that we do in neuropsychology. So, can you tell us, our viewership, what is neuropsychology in general?
Sure. So, in the most general, if you look up a definition, it's going to say the study and application of brain behavior relationships, which basically just means the overlap between what is neurologically or what's biologically going on inside your head, inside your skull also, but in your brain, and how that relates to our behavior, what we do. So usually with neuropsychology, we're a little more focused on cognitive aspects of that, but also emotional aspects and other things. But being that our brain can be the driver of our memory ability, focus, concentration, a lot of these cognitive abilities, basically
Mm-hmm.
everything we do, decisions we make, how we think, being driven by the brain. So it's really the study of everything in the world, but particularly how our brain affects these measurable psychological things like focus and
Mm-hmm.
concentration, especially things like that. So
Well,
hopefully that made sense.
yeah, no, and again, for our viewership, if you guys have questions or if you feel like you would like a little bit more information, definitely please use the chat. Some of the things we're going to talk about, if we can get into it all, can sometimes be really hard to grasp. So we're taking really large concepts and breaking them up into these little bite-sized chunks of information. So definitely use the chat if you have questions. So I really like that you talked about the applicability and what we're looking at in terms of how people literally behave. What is your brain telling you to do? Are you listening to what your brain is telling you to do? Is your brain like overrunning things and your body not responding, or vice versa? So just kind of thinking about what you do on a regular, what would you say I'm going to kind of jump around in questions. Just in general, what would you say a neuropsychologist does? Like, what would be the expectation for a neuropsychologist to be involved in a person's life?
Sure. The beautiful thing about it is that can be pretty broad. There's a lot of different applications for neuropsychology, which is beautiful. Probably a lot of people here are interested in psychology because it's so broad. You can do so many things as a psychologist. As a neuropsychologist, there's a lot. So typically, you might be in research, and then you're not going to apply things directly so often with, with a client, for example. But what I'm guessing we're going to talk more about today is the clinical side of things. Clinical neuropsychologists typically more involved in assessment of cognitive abilities, with the departure point being the brain. So not just saying, is memory good? Is this good? What are your abilities like? But let's make some inferences about someone's brain function from that, right? You have these abilities, therefore I think the stroke in this area of your brain is the cause, etc., right?
Right. So you talked about a couple of areas that you would look at. So you mentioned like memory or attention, some of those cognitive functions. What would you say are the general cognitive functions that neuropsychologists are looking at?
Again, it can be broad, but some of the main ones that, the indispensable big one, if we have a big 5 in personality, we have maybe a big 6 in neuropsychology of memory,
Hmm.
attention / concentration,
Right.
executive functions, language and visual spatial abilities. I think processing speed's another one that kind of gets lumped into attention, but it's not necessarily that. So I'd call that the secret 6th. But motor functions, social cognition, validity testing is involved a lot. So there's a lot of other areas, but those are the big 6, the ones you probably heard of.
Yes. And most often you probably hear people say like my memory is bad or I can't focus, and like assessment tends to be where you do see a lot of neuropsychologists coming in and assessing whether that area is working optimally or working appropriately based on your age and your education level, et cetera.
Mm-hmm.
So tell me a little bit about what you've been doing and like your interests, and we'll talk a little bit more of those clinical applications as well.
Sure. So I guess I'll start. So I do a lot of clinical work. Um, I'm housed in a specialty where the way our hospital works is I get to see referrals from all over the place. Mainly, I'm getting referrals from UNC doctors, but sometimes other community doctors. A lot from neurologists. So I'm seeing a lot of patients have epilepsy to help determine their cognitive function, especially for those looking for epilepsy surgery. There are a lot of cognitive and other variables to take into account before the neurosurgeon will feel comfortable cutting part of someone's brain out to stop their seizures. So they want to know as much about the brain as they can, this person's brain. So I will examine how their brain's working. Other neurosurgical applications I do a lot of: before and after tumor removal, before Parkinson's disease, deep brain stimulation surgery. I also see a lot of people with concern for dementia, that they or their family often have concern. So help with diagnostic differential of dementia. But I see, again, everything: brain injury rehabilitation, stroke, psychiatric disorder that's causing people to have memory concerns, sports concussion, part of the COVID clinic that we have at UNC occasionally, COVID long haulers. So that's the beauty of it, is that what type of patient or client is going to have concern about their memory or some need to know about how their thinking abilities are. That can come up in all over the place, right?
Right.
Cancer, chemo brain, HIV, all sorts of things can cause brain, thinking difficulties, and you might need a specialist who knows how to help identify what's the problem before we can get to working on it.
Well, I appreciate that you talked about one being able to get all these different types of clients walking through the door that are being seen for a whole host of different reasons. And the other thing that you talked about is like the assessment of before and then an assessment of after, particularly if surgery is implicated. I'm wondering if you could speak a little bit as to why that would be necessary or why that would be important. And then maybe we can talk about some particular locations in the brain that are being looked at so that our viewership understands, like, hey, why would it even matter that they're cutting the right side of the brain and you're looking at the left side of the body, et cetera?
Great question. And again, a note to jump in. I know we're formatting this where you're asking me the questions, but since you know just as much as me, maybe I'll get a chance to bounce a question back to you, or you feel free to just pitch in and answer your own question as well, of course.
That's fair.
Don't get stuck hearing me answer everything. But you had asked about kind of why would we do a pre and post something assessment or multiple time point assessments. Because again, the idea is that there's a couple, I guess, let me take that one step back and say what are some of the main purposes of what we're assessing. Again, I said generally to assess brain function, but one thing I hinted at was diagnostic. We can make guesses about what's neurologically going on in someone's brain. This part of someone's brain seems broken, for example. We would never say it that way, but to make guesses about what's going on in their brain. I think the tumor is affecting these functions, or I'm worried that you have Alzheimer's disease causing atrophy in your brain because these are the areas that looked weak,
Right.
much more than someone with no atrophy in their brain would. And this is the timeline of your decline and so on. But also for functioning, right?
Mm-hmm.
Which you hinted at earlier.
Right.
Yeah, you can guess about someone's brain. You can say, yeah, there's a tumor in their brain. Then the MRI person says, yes, I know. I saw it already. But how's it affecting them in their life? They say it's affecting them in this ways, but maybe you can measure what exactly is breaking down to help them function, right? Or does this person need a guardian? They're so impaired. Does this person need disability benefits? They say they can't work, right? I like to believe them, but also if we could measure that and get some evidence, that'd be extra great.
Right.
So there's that sort of bifurcation as well. But so to answer those questions, before someone gets epilepsy surgery, for example, let's say they want to cut out someone's left temporal lobe lobes being the most common site onset of epilepsy, and temporal lobe resection, aka cutting out part of the temporal lobe, being one of the big surgeries for it. You want to know what the left temporal lobe does before you cut it
Right.
out. First of all, in general, what's at risk here? Before you cut out part of my brain, I'd like to know what that part does and if something's going to change. So you would, part of that, oversimplified, but I might test someone's language and verbal memory especially would be typically left temporal lobe functions. In
Mm-hmm.
some people that might be more on the right, but we have ways of testing if you're left dominant or right dominant. Most people are left dominant, so that's why I'm going to defer from now on. Heretofore, calling left the language hemisphere.
Language.
Yeah, but so I'm going to want to focus on those abilities, especially, and answer the question of, is your left temporal lobe, besides causing seizures, is it even working?
Mm-hmm.
How good is it at doing its job? Because if it's not, then you're at lower risk actually for losing something if they take it out. Seems counterintuitive, but you want to do badly on those tests to have less to lose, to say,
Right.
well, it's already been affected by the scar tissue, for example, and the long-term effects of seizures. We're at a low risk here for taking this thing out. We're at good risk of getting rid of your seizures, which is good, so it might be worth it. But also, I'm going to want to test you afterwards to make sure we didn't cause any additional decline, and if so, updated recommendations, right? Maybe you didn't need accommodations before, and now you do. So I need that functioning ability. Maybe you didn't need much supervision before, and now you do. Or maybe a visual field cut sometimes.
Right.
Left temporal lobe, you might lose the upper right portion of your visual field. You just don't see stuff up there, or you neglect it.
Mm-hmm.
Usually that's not a big deal, but especially if you lost, for example, half your field from a stroke, I would need to know something like that. So there you go.
No, I think that's fantastic. I think while we're talking about it in this very simplified way, the brain in and of itself is the least simple muscle in the body. It's actually one of the most complex muscles in the body. And so the tests that are being done are not just, I wish they were as clear and cut. And like we could say that every area of the brain, at least the way we used to study was based on localization. And now it's more looking at how brain areas interact, how they engage. So it is super important to understand what can be lost or what, what this surgery is going to do, because those challenges that can come as a result of it can impact a person's life functioning, right? And so we want to help them be able to understand, as a result, here's how we're going to make these recommendations so you can function for the rest of your life. The brain is very plastic. It's a fascinating thing. Sometimes other parts of the brain can take over for some areas of the brains and sometimes not. So it's not like, oh, we just make this cut, everything is great. Sometimes it's a little more complicated than that.
Oh, yeah.
So, yes. So the post test definitely helps to share, like, hey, we did the surgery, everything looks good, you're free to go. Or let's do some rehabilitation just in case, because this looks a little bit off. Doing what you do, doing the assessment, looking at all the different areas of functioning and kind of assessing, like, is this part of your brain working properly, requires quite a bit of skill. So if you could tell us a little bit about what it takes to become a neuropsychologist, like, it's so many different areas of psychology plus a bit of neurology. How did you get so specialized?
Sure. Piece of cake. No, just kidding. So it starts with to be a clinical psychologist, you have to be a clinical psychologist. So you have to get licensed through appropriate means. Then legally, you can call yourself a neuropsychologist. That's not a controlled term. But to be a good, actually qualified neuropsychologist, you should have a lot of. There are some. I do recommend people look up the Houston guidelines.
Right.
For where a bunch of neuropsychologists got together to determine what should a neuropsychologist know. Okay. The idea was that you would have years and years of training, postdoc, pre-doc. You would have classes, academic classes, whether that's didactics that you got on certain placements, but also theoretically in your grad school, you would get some of these classes as well, where you get training in neuroanatomy, understanding of neurobehavioral syndromes, like what happens with epilepsy, what does a TBI usually do to a brain, what are some of the patterns of dysfunction that can occur from different illnesses and issues, what does ADHD look like, etc. So that's some of it, and then a lot of understanding in psychometrics, knowing the limitations and abilities of these tests to measure what we're trying to measure. So there's a lot. What I did was get obsessed with neuropsychology part of the way through regular clinical psychology grad school. So you don't have to be in a neuropsych-based track necessarily in your grad school. But I basically started to create that for myself as much as possible, doing practica, research, TAing neuropsych class. Then my internship was in a very neuropsych specific. It was a gero neuropsych track at a hospital. And then postdoc was here at UNC doing just neuropsychology, and now I'm doing it ever since. So hopefully that answered the question. But again, through lots and lots of training. But if you're curious of some of the specifics, Houston guidelines.
Yeah.
And then of course, board certification is an option, which I do. I am board certified to kind of just show that you've done those things. Right? It doesn't mean you're the best neuropsychologist if you have it, but if you don't have it, then we don't know. You might be fantastic and you might not, but it's the way of certifying. Yes, I have the appropriate training, and then you take a written exam about the bunch of brain stuff, and then an oral exam where you talk to a bunch of people about brain stuff and prove to them, what you're talking about.
It's a long road. I am starting that process for the board certification, so it is a lot. It's a lot of stuff that you already know, but then you have to study it again because the way they may ask you the question is very different. So it definitely like for anyone who is interested, you want to look at the Houston Conference guidelines. They will be slightly adjusted, I believe. AACN, which is the Association for something Academy for the Clinical Neuropsychology.
American Academy.
Thank you. I'm like, I should know what that first A is. During their last conference, they talked about different groups coming together to discuss the Houston Conference guidelines and make adjustments as necessary, given that a lot of work is being done virtually and there's a lot of changes with looking at data cross-culturally. Like, we need to make sure that they're putting those requirements into the guidelines so people can be trained appropriately to meet the 21st century and the growing diversity needs in our communities. So I look forward to seeing what those final results are. Mm-hmm. So just thinking about your role, as a neuropsychologist, you tend to see more acute type cases, right? Even though epilepsy is long-term, when they're coming to you, it's usually about a surgery, a pre or post, or someone is experiencing something pretty significant in their life, whether it's like a concussion or some other type of injury or a stroke. Those acute situations are really important because you need to get them in, get them assessed, figure out what surgical needs need to be done, and then do a post-assessment before they're out into the community. My question is more about the long haul, like after they're in the hospital or they've done their rehabilitation. I wanted to think about how we as clinicians can provide support for individuals who've had an acquired brain injury. Because you can see all sorts of types of clients that have different types of behaviors, different personalities as a result of an injury or a surgery. And so, or a tumor or things like that. So I'm just curious, what would you say, like, clinicians like myself, like yourself, should be aware of working with, individuals who have acquired brain injuries? Like, how would non-neuropsychologist therapists know how to support this community?
That's a great question. Yeah, it's a great question. So it can be informed by neuropsychological evaluation, but as you pointed out, we're typically going to see someone in a more acute state. Even if it's something chronic, we're seeing them because something's worsened usually recently, or some reason that why now, right? Mm-hmm. Why do we need to get this tested right now? But then you're right, after an evaluation, maybe a neuropsychologist will follow with someone and do some serial assessments, but they're not typically going to be the ones doing hands-on care, at least in their typical neuropsych role as an assessor for the most part. There are neuropsychologists involved in rehabilitation in some places, but that's not the norm. Okay. Normally that's going to be them checking in every couple of years or something like that, and then a speech therapist in North Carolina. I think most states speech, but sometimes occupational therapy will be the one doing hands-on cognitive rehabilitation. But there's so much more, like you said. There's cognitive rehabilitation, but then there's the emotional things. Then there's aspects of impulse control and behavior that you can't really rehabilitate the same way. That it comes down to non-neuropsychologists. It comes down to social workers and counselors and psychotherapists and everything, right? So yeah, I think it's hard for me to sum that all up for somebody, but a couple rules of thumb are just, you might have heard this, but that no two injuries are the same.
Exactly.
Right? Or no two presentations even of the same injury. So to not get in your head that you think you know exactly what a brain injury looks like.
Right.
It's always so complicated. And most often there's the injury being a small part of what's really going on with a person. It might have initiated a cascade of all sorts of stuff, but to get out of the head of this is brain damaged or something like that, we say, well, it was a hit to the head that sort of damaged something, at least temporarily, but also then it caused poor sleep, it caused fatigue, it caused emotional changes, because psychosocial issues. They're trying to adjust with the idea that now I have some limitations you often don't just hit your head too, right? At least the people I see.
Right.
They got in a
Right.
car crash and they broke a bunch of their body as well, and so now I'm adjusting to disability limitations that I didn't used to have,
Mhm.
pain, side effects of pain pills, sleep, side effects of sleep pills, and it snowballs, and so you get so much more than an injury, and then you get people who it never got identified, or it sort of got identified, but they always feel like it's being brushed under the rug, and they say, "Well, the neurologist said my brain swelling healed after a month, and this other stuff healed, so the rest of it's all in my head." And it's not, of course, but trying to
Yes.
explain this complicated thing to say, yes, that your brain injury started it, and even after the swelling, it started this big problem, right? The tornado went through town, and the tornado's gone, but there's still damage. There's still rickety structures and all sorts of issues left behind. Fires are still burning and whatnot.
Right. I love the example that you said it creates a cascade of different situations. And you're spot on with that because you may have had this injury, but it's not like it's all just nature, right? You have this cut, you have this tumor, you have this TIA. There's going to be a little bit of nurture mixed in. And what I mean by nature and nurture, of course, like how much of your environment is going to play a role versus how much of the physical effects or even your genetics, right?
Mm-hmm.
So as a clinician myself, I often will adamantly ask, especially in my intake, any history of brain injury. For my older adults, any history of stroke, any history of like surgeries. Often you have to be mindful that for some patients who have had brain injuries, they may not have a clear recollection of their injury, or they may not be aware of the deficits that are now present in their life from their injury. So relying a lot on family input, if there is family that can provide an account of what took place or what the injury was, is really important. Outside of that, trust your gut. I would tell a lot of non-neuropsychologists that if you see something that seems a little bit out of what you would consider your norm, you might want to be curious about it. I do teach a lot of my interns to be very mindful of physical things, right? Slurred speech, especially if it's like a really quick onset or an acute onset, that can be a sign if they're not intoxicated, right? Being mindful of physical movements, just being on target with the client, like asking questions. We don't tend to think about asking as many questions about a person's physicality. We're always thinking about supporting them emotionally. And if you do have clients who have injuries and have had lots of, or have had surgeries or some issue with the brain, maybe your type of treatment is going to look different. Maybe it's not going to be insight-oriented treatment because they may not be able to go there. It might not be cognitive behavioral because maybe they can't do the homework. So like you want to be mindful of what you're recommending so that, and it might just be supportive. Dr. Drexler, one of our professors from the university, was a wonderful professor. And that was something that he talked about, the difference between supportive therapy and then like other types of clinical therapy that's focused on different problems. Sometimes it's a matter of being able to help the person understand that there is a loss. There's a lot of grief and loss work with these patients as well, because they're adjusting to a new norm, right? If you can't walk as well as you used to, or you can't use your arm, I see this with a lot of stroke patients that have paralysis or hemiparesis. They're having to adjust to not being able to use that body part. So sometimes it's being able to help them deal with the frustration, irritation, and loss of that function. So I think as a non-neuropsychologist, if you can tap into a person's medical record and ask questions and get information, even secondhand, if it's from a family member, it can be really helpful in thinking about treatment going forward. So I kind of stole the microphone from you on that one, but
You did great. That's what I wanted you to do.
I wanted to, though, kind of think about the challenges that come up when communicating the
If
science.
I can also jump really quick, sorry.
Right,
We
go
have a
ahead.
question in the chat, and I was wondering if we can switch roles and I can ask you it.
Go for it.
All right.
Sorry about that. I missed
No,
that.
no, it's just a couple minutes ago. Michelle Thompson was asking. She wants to know, Dr. Ball, can emotional trauma present itself similar to physical trauma in the brain?
I would.
And the answer, of course, being in what ways can it, in what ways is it probably not?
I think it's such a loaded question, because I would say yes. And there is research that looks cross-culturally at some of the types of emotional trauma that folks have experienced and how it physically manifests. And Matt, jump in if there are other points that you want to address. I think of some of the really historical work that was done with the Vietnamese refugees, where they experienced a lot of just war-torn community, and just war is awful. But their trauma that they experienced, whether it was just visually experiencing it or being in the midst of it, there was a lot of the mutism that was taking place in that community. And of course, it wasn't quite understood as to why, but that was a lot of emotional trauma. There are also, I wish I could think of the name of the researchers, but I was not thinking about that right now. There's also research done on domestic violence survivors. And there's a book, Vicarious Trauma by Judith Herman, I think is the name. She talks about, her focus was more on borderline personality disorder, but she did talk about a lot of those folks experiencing intense emotional trauma over the course of their lives, and it impacting their ability to function, their decision making. So in terms of it manifesting like physical trauma, to some degree, yes, it can impair cognitive functioning like decision making or judgment. It can definitely impair one's ability to take in any type of new memories. We know when a person is in a state of trauma, they're not taking in new memories. Like, that's it. Their brain is like fight, flight, or freeze mode. So emotions are extremely important and can actually create physical responses. So if the emotion is strong enough, it can definitely mimic like that physical trauma. So hopefully that answers your question, but it definitely depends. Not all emotional trauma experiences will evoke a trauma-like response in people. There's some research that was done by the VA on, I'm so bad with my research, but it was done by the VA on individuals who were in the Air Force, and they were looking at the impact of executive functioning and PTSD. So individuals who had higher levels of executive functioning were less likely to experience PTSD symptoms after being presented with potentially traumatizing events or situations. And I don't remember what year this was done, but that I found really interesting, because the more ability you had to organize within your situation, the more likely you were to be able to function appropriately post the situation, like organize your resources, not necessarily feel frozen or stuck. So I thought that was actually pretty interesting in terms of how situational factors can impact the brain in pretty significant ways if the person doesn't already have the ability to organize themselves in general to get out of those situations. So just a couple of tidbits about that. But to answer your question in the simplest form, yes.
Yeah, same. I think, put it short, yes. One of the classic differentials in neuropsychology you probably learn about early on is that it's common to get a referral of, is this dementia, aka some brain illness, neurologic cause of being severely cognitively impaired, or is this depression? And when you first hear that, you're like, what? They're way different. But there's a thing called what they call pseudo dementia, which maybe we need a different term these days. But the idea that someone's basically so depressed or otherwise emotionally traumatized, PTSD can do it, that they become so cognitively impaired and so disabled by it that it can be hard to tell the difference between that and someone whose brain is completely shrinking away and atrophying, like in Alzheimer's or one of these other dementing illnesses. There usually is a different pattern on neuropsychological testing, including just in general emotional trauma versus physical trauma. It can look pretty similar in the real world, but if you really need to get to the bottom of it, you don't always, but if you need to, neuropsych can hopefully help with that. But either way, your job as a non-neuropsychologist is going to be to help this person in a similar way, hopefully, right? To support them either way. You're not going to be damaging any brains anyway. If it was brain damage, right? You're going to help them cope. And so hopefully you're going to do that either regardless of the cause. But if it's emotional trauma that needs to be worked out, hopefully you're on that anyway. So yeah, again, I would work on the emotional pieces and the coping pieces, one and the same.
You know, we do hear a lot of the saying, neurons that fire together wire together, and that the belief that brain plasticity, I'm going to say, stopped after the age of 5 has kind of been done away with. Like, now the understanding is that brain plasticity is maintained across the lifespan for the most part. Of course, as you age, it does become a little bit more challenging to create those neuronal connections. However, there is so much research now with exercise. Wendy Suzuki is a researcher, a neuroscientist in Stanford, who is looking at the effects of physical activity like exercise and its impact on the brain long term. So if you're not exercising, I highly recommend it. Like she says, it's like a 401k for your brain. You might not see all the benefits now, but definitely they will kick in as you age. So really, it's important to understand how your brain functions from day to day, how you engage, and also notice if things start to shift. There is normal decline in aging, right? So some people tend to lose their memory. For all the mothers, there are cognitive changes in pregnancy. That pregnancy brain is real. It is real, and there is research that shows it's even sometimes more severe than clients who have concussion. So just to be mindful of that. If you have clients that you're working with who are pregnant, helping them understand, like, if you can't remember things, if you're constantly tired, if you have no energy to complete other things, that is pretty normal. If you can't find the words for certain things, that is also pretty normal. So in thinking about our questions, unless there are any other ones, anything you wanted to add, Matt?
You covered it.
Okay. Just quickly going through our remaining questions. What would you say are some of the challenges that you experience in communicating, like, the science behind neuropsychology to the general public? Like, what are the things that you notice? I apologize if you hear my toddler crying in the background.
Oh, there it is. I heard my child crying through the wall, but it's more soundproofed, I guess. But yeah, so communicating research to the public, I wouldn't say I'm doing that a lot, but in my role, more often almost counteracting or just trying to go counter to what people have heard can be really difficult. I think the media what will happen is we present research to a research journal, which the general public does not read, right? They won't want to anyway. It's presented in the driest format possible, maybe to exclude people, but to be accurate as well, and presented very carefully. And then in order to present it to the public, some media source has to take and try to distill the interesting parts of it. And it's almost impossible to help themselves from sort of saying, so what you're saying is this thing that you're not saying, right? Because that would be the next step and that'd be the cool hook. And so I think a lot of research gets taken away to mean something else, or, brought a certain way. And then the listener also wants it to mean something else. So they're even probably exaggerating in their own head what they heard from CNN or wherever, it doesn't matter where. They all do it. Who has exaggerated it from somebody's, probably just the abstract, not their actual article anyway. And so then the scientist is like, grr, why do you guys have to twist my words all the time? But then the public's saying, grr, why do you scientists have to present everything in such an inaccessible way where we have to make the meaning ourselves from it? So I think this is just a greater issue that's not necessarily involved in my clinical care, but this disconnect between science and consumption of science. And it happens a lot with the brain. I'll say on my level, when I encounter it the most, is panic about the effects of concussions and COVID on the brain.
Right.
That they both certainly cause, and they both been, COVID's less long, but concussions were constantly under-recognized, underappreciated. And so in the spreading of this information, we got Will Smith movies, we got articles all over the place, right? Everyone's aware now. The NFL can't get out of the shadow now of their own doing for hiding it. But so now it's been blown up and put this giant spotlight on it to where every single person who ever hits their head thinks they have chronic traumatic encephalopathy. And every person who ever had COVID thinks they have every neurologic manifestation possible of it. It's this overcompensation, right? And so it's really difficult to go, but you hit it for so long, the solution is blow it up. And then it's way too blown up. And then I see so many patients coming in with either a mild concussion or with COVID, or there's some other things saying, my brain's broken. I can't remember anything. I know I have CTE. And then when they do great on all the tests, they say, I don't believe your tests. I actually just believe my own anxiety. And I'm certain that I have every disease. I have Alzheimer's disease at the age of 23. I know it because of my butterfly landed on my head. And I'm going, oh, man. And I'm not saying this is the case in general, right? We do need to listen to people. But there's somewhere the way that it's being presented in the world and the way people are hearing that. We know the relationship between media saying scary things and then people watching media to go, what should I worry about now? So that's,
I think it's super important, right? Like, I'm certain you get folks who have done a Google search and they meet all these criteria based on their Google search. And then they come in and they are adamant about, I have this. And I know many of our clinicians probably also experience this. And some clients are pretty accurate, right? Yeah, I have depression. Yeah, I'm pretty anxious. I took this online test through WebMD where they feel like now they have diagnosed themselves. And sometimes that can be really helpful. Other times, I think you're right. The research does get blown out of proportion. My favorite example of this is the 7-minute abs. Like, all you have to do is work out 7 minutes a day and you're going to get rock solid abs. And like, you're not going to get those abs, not 7 minutes a day. But the concept behind it was about, focusing in on particular areas for a minimum of 7 minutes, not just only 7 minutes in your whole workout. And the research behind it. But that wasn't necessarily what got caught up in media. It was like, only do this for 7 minutes and you're going to get these rock solid abs. And so people are doing these activities for 7 minutes and wondering, why don't I have rock solid abs after like a month? So there is a real challenge in presenting the research data to the public. There's also a real challenge of, I would say, political forces appropriately using the resources to write bills or policies that are effective, because they don't always read the full research and they don't always understand the statistics behind it, right? So they elicit help for that. But it is very commonplace for people to take parts of the research and the parts that suit them and promote that, right? So that's why researchers present a full picture with all the data and say, here's the caveats. Here's what was significant. Here's what wasn't significant. We don't just boil it down to one thing. But because not many people are well versed in that research, especially for the public who wants to just know what to do, it can be really hard to communicate that. I have to say, I think that things like TED Talks to TEDx has been really supportive of looking at the research and bringing it out to the public in a way that's digestible. But there definitely is more to be done. So just thinking about all of these things, why would one of our therapy patients who clearly has memory problems do well on a neuropsych test? We're going to throw that question at you.
Sure. So to answer that, we have to think about what are we actually testing here, right? We say, I'm testing brain function on a bunch of neuropsych tests. What you're testing is under certain circumstances, testing circumstances, which are usually in a quiet room, minimal distractions, usually a brief period of time. They used to do these forever, old school version of neuropsychology. Now, probably talking 2 hours worth of a bunch of tests, 3 hours. So under a limited amount of time, structured tasks, what someone's cognitive capabilities are in many ways. Okay, so can you memory at your best, right? With a good night's sleep, hopefully, and clear instructions and so on, when given the chance to hear things multiple times and learn them, etc. Right? Can you focus? Can you language, etc. So that will tell you that that has pretty good neurologic criterion validity, meaning it's good at looking at the neurologic, the brain capability at its best. To say, oh, well, you wouldn't be able to do this if you had a giant stroke in the language part of your brain, so you can still language. You wouldn't be able to do this if your brain was shrinking away. I don't think you have Alzheimer's disease. That capability would be lowered, right? But what if I have sleep apnea and I'm exhausted all the time and I'm under mountains of stress and PTSD and these emotional things that that Michele Thompson asked about. All these things that are holding your brain back, right? So you might still, and the patient might tell you, sometimes I can remember stuff great. I don't know what the heck is going on here. I can remember it good. And I go, that's because the memory part of your brain's not broken. But you're not wrong that you're forgetting more. I'm sure you are more forgetful, right? So this can happen, especially if it's emotional things, especially if it's temporary things like being tired or poor sleep or, apnea, things like that.
Not eating.
Yeah. Medication side effects. Some of these things include mom brain, chemo brain, some of these things that might not show up in a big way on neuropsych tests in your average patient. They're probably not going to much, but they're going to affect people in real life. They certainly do. So no one comes in and says, I have mom brain. And I go, you're wrong. You did great on memory scores. I go, the good news is your brain can still work. I believe you that it's not working, especially at certain times, especially when you're tired, especially when you're stressed, especially when your hormones are out of whack or your transmitters are out of whack. You can push that all aside for a couple hours and perform amazingly with me on testing. So that's good news. Again, the analogy is the engine works in your car, but it's out of gas too often. And the tires are bald and it needs to tune up and all this stuff like that, right? So it can work. Don't give up on your engine. We just need time or therapy or, whatever it is, right? Vitamins, whatever it is. We're trying to rest is usually the big one. To get this thing rolling like it could. That's the good news is there's a fog or there's some side of anchor holding you back. If we can get this junk out of the way, you got the engine to start speeding it just like you used to. So that's why. So when you work with a therapy patient and they're forgetting stuff a lot, it doesn't automatically mean that some brain part is broken, some neurologic thing, but it doesn't mean that that's not real, right? Of course it's real. Of course they're forgetful.
Well, right? You're talking about working under an optimal situation, ideal. It's quiet. You have time and space to think. Maybe there are some time tasks, but it's not like you have too many interruptions. And so that's not realistic of everyday life. People are under stress. And it also begs the question, do you need to take on all the things that you're doing? Can you delegate? For many clients that I see who are juggling everything in their head, it's like, do you have a planner? Let's write it out so that you're not constantly bombarded. Like, your memory isn't bad. You're just you're going overboard. You're way past the 7 plus or minus 2. You're like at 15. So we want to help people understand how their day-to-day actually can make an impact on their actual cognitive functioning, their brain functioning.
Exactly.
So I know we're at time, but I want to quickly throw out this question and have you share your thoughts, and then we'll wrap up. Given your experience with working with patients who have COVID or had COVID, what are some of the neuropsychological impacts of COVID-19, and how do neuropsychologists work with this?
I think this overlaps well with what we're just talking about, so we should be able to cover this quickly. That's good news. So again, to get at the WebMD idea, you'll hear about some rare cases of COVID manifesting itself neurologically, causing neurologic symptoms, causing brain swelling, or all sorts of other things. Those are extremely rare. They're real, but 99% of the time, if you have a patient who had COVID and is worried about their memory or thinking abilities, it's usually not that COVID is ravaging their brain in that way. It's usually sort of like a mild concussion that we talked about this, where there's such a constellation of factors. Again, 90-something% of the time, it's the COVID-caused fatigue, COVID-caused breathing issues, COVID-caused headaches, COVID-caused, again, panic is part of this, or just, emotional things of feeling broken, just feeling traumatized from having to have gone through what you went through with your illness, and so on. So what they might call peripheral factors, not direct damage from COVID, but not to minimize COVID's role in that, right? It's just that it started this thing that now these people will say, my brain's completely broken. We go, again, I think it's not broken. COVID didn't ruin your brain. That's good news. It has temporarily fogged it the heck up, though.
Right.
And we need to get, mainly due to fatigue, stress, all these other things. So hopefully with time and with working on those things, we can unravel this this knot here and get you back, because again, your engine can work. You got the pieces. Don't give up on getting that better. This is the good news, right? Otherwise we'd be like, oh, broken car, sell it. Whatever. Junkyard. Your brain, you're not going to the junkyard. This is fixable. And that's what I see a lot. It's that combination of all that junk, and then people are stressed. They had to quarantine, and probably drinking some alcohol during that. They're on medications for their other symptoms. There's everything. Oh, it gets so difficult. So it's so real. It's so obnoxious. Almost 9% of the time, brain's not broken. Is the ray of light here, is that this can be gotten back from, theoretically.
I appreciate that. And I know I said I had one last question, but I do have one more. I promise we'll wrap up. I wanted to highlight the fact that neuropsychology has been a field that has been around for a long time. We've been studying the brain. Brains are generally pretty much the same. However, access to care is not. So thinking about, how working with individuals of diverse backgrounds, just what are some of the difficulties in applying neuropsychology to folks of diverse cultural backgrounds? And how do you think neuropsychology will adapt to this changing world?
Yeah. So obviously this deserves like a 4-hour answer. But to bullet point some of these, a lot of the history of science in general and medical science, but including in the neuropsychology world, we have a lot of research showing effects of things on cognition, for example, correlation of brain parts with how they manifest behaviorally, done mainly on white people, mainly certain ages, mainly certain SES, education levels, certain demographics, not that diverse, let's say. And we utilize a bunch of tools for assessing cognitive functioning and comparing people to normative data. Usually on those same groups, right? The white, educated, and so on. That might not represent the patient that we're looking at, right? So comparing them to this normative data that's supposed to be representative may not. Which is a lovely thing about this test retest that we talked about in the very beginning. If you have someone's own numbers from before whatever, then you compare them to themselves and not have to worry about biased in normative data sets, for example. But there's that. There's norms, there's validation of these tests. That we've shown that this test is great at detecting Alzheimer's in white, very well off people with no disability. That's another thing in research diversity, etc. Right? People with spare time to join studies. So that's a big one, is applying this research, especially all these tools that we use, to a certain demographic that's changing in America and is becoming less and less relevant to patients. There is plenty of research trying to cross-culturify basically the norms and validation of a lot of these tests, or to make new tests that have been designed with that in mind. But there's not a lot, and that's why there's been some big initiatives in these neuropsych associations to say, we're not keeping up with the times. If things keep going, we're working on it slightly, but diversity in the world is going like this. There's already a gap, first of all. We're already not meeting the needs, but that's going to keep spreading if we don't up our trajectory of diversifying our research and so on, right? Making it culturally appropriate. So that's part of it. Other things about, again, how we spread research to the community. You might be speaking a certain language in a way that we need to diversify to not just the lay person, but all different types of lay people or non-scientific people of all types, and including with how you even talk to a patient. We can break it down all the way to the things that we have in common with non-neuropsychologists, which is how do you approach some of these topics with somebody, depending on their background, depending on their culture, depending on their individual, their own nature, you know? So yeah, I don't know if some of that made sense. You want to fill in any gaps that I missed?
No, I think that's super apropos. Like, we do know that the research that we've been using has missed a large part of the diverse community for a very long time. I can't think of his name, but something Guthrie. His book, Even the Rat Was White, talked about like the disparity in, communities, of color, because there wasn't research being done on them. We can also spend lots of time talking about access to care and the different resources that are available, who gets access to a neuropsychologist, things like just things like that. So what are we going to be doing in the field to adapt to this changing world? Well, I think already we're seeing some of those changes, the big initiatives that you talked about with the neuropsych communities, the 2050, which is literally working towards diversifying the research data. There's lots of entities involved in that, and that's fantastic. We're not quite sure what impact it will have, but do think that it will make a difference in terms of like where the cutoffs are in some of the things, but it might have an even more different impact. So it's something to be mindful of. And then lastly, with this technology, we're getting a broader reach. So maybe we might be able to get a lot more of those folks who we couldn't capture ahead of time. And lastly, I do hope that by diversifying the field, the community, we can tap into building trust in the medical field and in the clinical field. Because I know, especially in the Black community, there's still a lot of distrust for medical professionals or clinical professionals. So we want to make sure that we are doing that. So with all of that, I think we have, a nice conversation of that we can talk about on another day, what it means to diversify the field. But are there any takeaways that you want our viewership to take from our conversation before we wrap up?
Not specific ones that I can think of. I would just say, sort of in general, if you're interested in this, to follow up, I think there's no shortage of areas to follow up on this kind of thing. But look into neuropsychology. Don't be scared of it as a field just because there's often a lot of big jargon, and the brain is so complicated. Even if you're not going to be a neuropsychologist, I think it really helps to learn about these kinds of things and just to be familiar. And again, don't be scared. Yeah, it's popping up. Don't be scared. Don't let nerdy, old school people scare you away from actual knowledge just because it seems like a certain club of a certain type of people or way of thinking. This is applicable to so many things. So, well, join the club.
Yes, definitely join the club. Representation matters. And also really being able to know the research. I mean, unless you're going to do a deep dive in statistics, not saying you have to do that. I do encourage it, but like know the research and know what's out there so that when you start seeing these polarized responses to the data, you have a really good, clear, informed decision or informed idea of what that research is showing or sharing, because that's really, really important. You know, there's so much misrepresentation of our data that like it's sometimes hard to argue for a position because people are like, no, it's this. And it's like, well, the research actually shows this. So I think, everything that you've shared has been so important. I really appreciate your time. I think we should do this again. There's a lot of things that we can talk about in terms of the brain and brain function and, what is normative and what is considered abnormal. But we'll definitely have to pause that for another time. And thank you for joining us.
Thanks for having me. Yeah, this is amazing. I would love to do it another time. I want to make you talk more next time because your input was fantastic. Don't just be thanking me. Thank yourself, and I'm thanking you. So it was fantastic.
Awesome. Well, we'll definitely have you back. And for our viewership, thank you so much for joining us. This has been a really lively discussion about neuropsychology and looking at what we do and how to essentially support folks in the community around understanding how brain function works. And if you are a clinician who finds yourself working with individuals who have acquired brain injury, definitely be curious, take your time to learn a little bit about the injury if you can. If you feel like you're still not sure or they don't know if they've had an injury, a lot of people don't sometimes recognize that they've had a head trauma that was severe enough that needs treatment. If that's occurred, and you have questions, it might be a great opportunity to recommend that they get a neuropsychological evaluation so that it can help support your treatment. So if you have further questions, you're always more than welcome to reach out to us. Also, if you are interested in doing a topic or sharing your knowledge, definitely check out TogetherWell's platform, become a member, learn more about the many resources that they have to offer and how wonderful an organization they are. They can support you in building your own workshops and connecting with other members in the community that, as clinical psychologists or as clinicians in the field, sometimes doing this work can be a little lonely. So you want to connect with others that share your same passion for providing support for not just our clinical community, but for the public as well. So with that, we will bid you adieu until next time. Thank you so much for joining us and have a wonderful evening. Bye-bye, everyone.
Thanks, guys.